My name is Dr. Elizabeth Willison, and today I will be teaching you about what the pelvic floor is and how it works. This is a picture of me and my family just recently, this last summer, when we went to Alaska for the first time. I have my doctorate in physical therapy, and even before I graduated, I started learning all about women's health and the pelvic floor. I became a certified pelvic rehab practitioner, and I also got board certified in women's health. I started my own pelvic rehab clinic in West Texas, where it quickly grew into a successful practice within a couple of years. I transitioned out of ownership earlier this year and I moved to Utah for family reasons. I've also taught anatomy and physiology in professional programs, so I get excited and nerdy about how the body works. I have seen and treated thousands of patients over the last decade, but the majority have been women in all stages of life. From a 7-year-old girl is the youngest I've treated to a 99-year-old great grandma, all with pelvic floor dysfunction. And this is just to say, you can trust me that I know what I'm talking about. So let's dive in. The pelvic floor is mysterious to a lot of people. So when I show you this, I'm just showing you, we're going to look at a diagram next. This shows what the pelvic floor looks like, but this shows you that it is underneath a bunch of structures. So you can't see them, okay? Just like the other muscles in your body, you can't see them. But the view we're going to start with is if you were to open the legs and we're looking up from the bottom, we're cutting away all this stuff and we're going to look at those levels and the layers of the pelvic floor. So there are 3 layers, the most important ones, and there will not be a quiz later, but the most important ones that we'll talk about are in the first layer, which are the superficial perineal muscles, and the deepest layer, the levator ani or pelvic diaphragm. So this is what it looks like without all of the extra stuff, okay? So here on the left, you have a picture of those muscles with the pubic bone at the top, and this individual or the model is sitting on where the tailbone is. So we're looking from that same viewpoint with the model laying on their back, but we just can see the anus here and the vaginal opening and the urethra, or where the urine comes out. Okay, so feces coming out here, vaginal opening, vagina, and urethra or urethral meatus, the hole where the urethra ends and the urine comes out. So we've cut away the labia majora, the outer lips, where you have more thick tissue and hair, and then the labia minora, where you don't have hair, it's a thinner tissue, more pink in color. We've cut those away, and inside you'll see those 2 openings, the urethral opening here and the vaginal opening here. So you can kind of see what I'm talking about. Labia majora, labia minora here. This picture on the right is a female cut right in half, right between the legs. So we get a cross section of what we call it, okay? And so here again, the same area, okay? Sometimes it's hard for people to picture, but this is the urethra where the urine's going to come down out of the bladder. Behind that, right here, okay, so we have the vaginal opening, and this is the vaginal canal, or what we call the vagina. So this whole thing, when you're looking at it from the outside, you can see the labia majora and minora. We call that the vulva, not the vagina. It's like calling the mouth and the lips the throat. It's different, okay? So the throat part is the canal, the vaginal canal, the vagina. It leads up to cervix and uterus here. So this is where we grow a baby. You can see it already lays kind of on top of the bladder. So if you've experienced pregnancy and strong urgency to go to the bathroom where it feels like the baby is sitting right on top of your bladder, you are right. The uterus gets bigger and bigger as baby grows and it weighs down more right here. So you have to go to the bathroom more often. The bladder is shrunk. You can't go, it can't fill up as much because there's just not as much room and you have more pressure on it. Okay. So other things to note in this picture is that you have what's inside the lips, okay, the labia majora and minora, okay, where the urine and the vagina is, where the urine comes out, where the vagina is. Out of the lips, you have this area called the perineum or perineal body. This is a little divider. And then behind that, it's mostly just like a fat pad. This yellow is fat. And then behind that, you have the anus right here. So this is the opening where the feces comes out. Inside the anal canal, then you lead to the rectum. So all of those different tissues, you've heard these names before, I'm sure. And again, I'm using anatomical names. And this right here, this cross section of these, they have some kind of stripes right here, and then they look a little bit different here, but they're pink. They kind of go through those canals and would essentially close them. Those are your pelvic floor muscles. Okay, so this is also why we should wipe from the front to the back. So you don't, and you have this nice divinely designed divider right here to protect these structures on the inside from feces and bacteria getting in them. So you don't get a bacterial infection like a urinary tract infection. So wiping front to back is important. The other thing to note, and I'm going to show you a different picture here, is that they are on both sides. So I've taken out the abdominal structures and the structures within the pelvis, those ones I just showed you, the bladder, the vaginal canal, the uterus, even the urethra, all of those are removed here so that you can see and focus on the muscles from the top view. I like this top view because you can see how in God's infinite wisdom, these muscles were designed like a hammock and they interweave together to give them a lot of strength, which is important because one of their roles is support. So not only do they support the bladder and the uterus and the vaginal canal and the rectum, but they support our abdominal viscera or organs as well. And you think, okay, so we just talked about pregnancy a little bit. As babies get larger and weigh more and just like grow, that uterus also growing, the pelvic floor muscles need to be able to accommodate that growth. And when you go running and jumping, the pelvic floor muscles need to be able to support the abdomen and the contents. When you sneeze and cough and laugh, same thing. When you lift something or someone heavy, same thing. We really need good support, which a lot of times means strength as well in these muscles, but they are designed in a beautiful way that already is giving them a lot of strength. So very important muscles, even if you don't think about them much during the day, very important muscles, okay? So again, another view of the female pelvic floor. This I like because even though it's the same viewpoint as before, where the model is on its back, okay, the nice thing is now you can really see the sacrum or the bottom of the spine and the tailbone or coccyx. That's the very tip, okay? of that spine. And you see how it even attaches into the anus here. We have ligaments here that feed into pelvic floor and support that really well as well. So you have not only support coming from pelvic floor muscles, but you have stability. These ligaments and the pelvic floor muscles that they interweave with are going to stabilize the spine and the pelvis. Another structure that we see here that you couldn't see before very well is the part of the clitoris. Okay, so this is the clitoral hood. The clitoris is bigger than we give it credit for, but we're only seeing part of it here. So the head of the clitoris here and hood. So you see how this feeds into the pelvic floor muscles. Okay, so a sexual appreciation organ, and these muscles will help with the erection of the clitoris during female arousal and sexual appreciation. And then this muscle here, bulbocavernosus, but again, no quizzes later, this surrounds those two openings. So you can see that if we were to contract this muscle, it will get smaller and it will help to cut off this opening and this opening. So this is an important muscle if we are leaking, okay, because this muscle isn't closing off like it should, and we'll talk about that later. And then also if we're having a hard time with any type of penetration, such as sexual activity or putting in a tampon, this muscle can be at fault because it's also the bulldog of the pelvic floor. My neighbor used to have a bulldog, and every time it sensed or saw or smelled something getting too close to the house, it would go wild and just bark so much. And that is what this muscle will do for the pelvic floor. If there is any feeling of being unsafe in the body, any anxiety during sexual activity, this will close the door. Another thing to relate this to is during vaginal delivery. So we need this door to be open and stretched during vaginal delivery so that the baby's head, most of the time it's the head that comes first, thankfully, but the body too, just the whole baby needs to be able to come out. So if you are feeling unsafe, anxious, scared, this door is going to want to close, and the baby is coming. So it forces the muscles to tear in order to get the baby out. If you have had an episiotomy where they cut the muscles to help the baby come out, then you are going to have not only this muscle cut, but also this muscle here, which you see, this is kind of like a trampoline muscle where it really feeds into that perennial body that I was mentioning earlier, that hill or space between these structures on the inside of the labia and then the anus. So it's going to kind of support and tent the area. And if we lose that with injuring it via cutting for an episiotomy for vaginal delivery, then we're losing a big support system. And this might be why you feel or contribute to the fact that you can feel a lot weaker and not have as much support in your pelvis or pelvic floor after delivery. And it heals and can take time, but it depends on how severe it was, but it can heal. But that is one of the reasons why you might feel pressure, heaviness, or weakness, or lack of support. So now that you've had the lay of the land or the lay of the floor, so to speak, I just want to reiterate those different roles of the pelvic floor muscles. So we have sphincteric control or continence or staying dry, both with urine and feces. We have a supportive role that they play to the organs inside the abdomen and the pelvic region. We have stability and posture that they contribute to, and then sexual appreciation, sexual function. And something that I will be explaining more later is that they coordinate with respiration or breathing. And we will talk about this as the sump pump. Again, preview for later on, but those are the 5 main roles of the pelvic floor. So if you have any issues in any of these, we are calling it pelvic floor dysfunction. Okay, pelvic floor dysfunction is extremely common. Most people assume it only happens to women, but everybody has the pelvic floor, so it can happen to anyone. I have a picture in this next slide. This is an example of everybody who can have pelvic floor dysfunction or PFD. So we assume that it's going to be mostly with our pregnant and postpartum population, when really, if you've had chronic back pain, if you are aging, your tissues change. I've worked with, like I said, pediatrics, young, heavy weights and lifting, but also high intensity athletes and males. I worked with a lot of military in West Texas, military members, and any of these people can have pelvic floor dysfunction. And so it doesn't look like you might think it looks. And you cannot assume that somebody, just because they work out a lot or they're highly active, that they don't have pelvic floor dysfunction. And it is something that's hard for people to deal with too, because it's not visible. So, there you go. Now, I wanted to show this slide because this is what people think is happening. So there are a lot of symptoms of pelvic floor dysfunction or PFD. There's bladder symptoms like urinary urgency and frequency. There's bowel symptoms such as constipation and hemorrhoids. There are sexual symptoms like pain or lack of pleasure when you're having sexual activity, experiencing sexual activity, as well as abdominal muscle separation, diastasis or pain in the abdomen, scar pain, hip pain, back pain. All of those are signs of pelvic floor dysfunction. But today, I just wanted to focus on the most common thing that people are aware of when I come to talk to them or they come to pelvic therapy is this leakage of urine. Urinary incontinence is what we call it. And this is what they think is happening. They think, okay, so I have the bladder, it has urine in it, and if I am leaking, then my pelvic floor muscles are not closing that like it should, and therefore they're weak. And if I just strengthen my pelvic floor muscles and get them really strong, then I will stay dry. And the sad thing is that this is not correct and accurate. This is an oversimplified version and explanation, and it is simply not true for everyone. You can have weak pelvic floor muscles from being too tight. So when somebody sees this, they think, I need to do those Kegel exercises because it must be that my pelvic floor is too weak. But if it is too tight and not functioning as it should, because it can't move and contract through the whole range of motion that it has, then those exercises, those Kegels, it's not going to work. It's going to make things worse, probably, or maybe improve some symptoms, but make other symptoms worse. So in order for a muscle to be truly strong, it needs to have good range of motion. And when all we're doing is squeezing, and we're not focusing on letting go, then we are not doing what's best for our pelvic floor, and we're not completing the picture. So again, this is not accurate. We're tempted to say this is accurate because we want simple explanation, but it's not. How we get good motion in our pelvic floor is breathing. So let's take a moment to assess our own breathing. How you're going to do that is you're going to place a hand on your chest and you're going to place another hand on your abdomen. And I just want you to breathe for 2 or 3 breaths. And let's just see where you're feeling the movement? Are you feeling it here in the chest? Are you feeling it in your hand that's on the belly? Doing belly breathing. See how long those breaths were. Were they like a 2 count? 1, 2, out 2, in 2, out 2? What do you think? So now we're going to change where our hands are. I want you to put your hands on your rib cage. So you're going to cup your hands like a C position with your hands, a C shape, and you're going to place that just underneath your bra line on the outside of your ribs. Okay? Same thing, I want you to breathe and I want you to feel where your hands go. Do they move at all? Do they come forward? Do they go backwards? Are they coming out to the sides? Just see. So what we should feel is that the chest should not move very much at all. Your belly might move a little bit, but most of your movement should come from the rib cage going out to the side, what we call lateral excursion. So I'll show you an image of a Coke can. And hopefully that is not offensive to anybody. If it is, you can close your eyes and pretend it's a Sprite can, okay? So in this example that we use, or analogy of the Coke can, the top of the can is your diaphragm muscle. Yes, the diaphragm, your breathing muscle, okay, it is the top. Your abdominal muscles wrap around the can, and then the bottom part of the can is your pelvic floor or your pelvic floor muscles. So when we breathe, we use that top, it comes down, the diaphragm will flatten out because it sits like a dome right underneath your lungs and inside your rib cage. And when you breathe in, it flattens and pulls down and kind of moves down, pulling the air into the lungs, and it would put a little bit of pressure on your abdomen. So that's why your abdomen kind of moves out a little bit. But to accommodate most of that change in space, we see the pelvic floor lengthening and coming downward as well. So this is the sump pump. You have the top and the bottom working together with every breath. So every inhale, pelvic floor has to come down with diaphragm. So diaphragm comes down and flattens. Pelvic floor also opens, lengthens the same time. And then you exhale and they both come up. So that is the pump where they both are working together. And that is why we shouldn't be doing belly breathing, because I have found over the years too, if you cue someone or tell them to do belly breathing, they actually are using other muscles, their abdominal muscles, for the breathing instead of using their good diaphragm muscle, which is supposed to be the muscle that you use for breathing at rest or quiet breathing. So most of the time during the day, you should be doing this rib cage breathing, or we sometimes call it umbrella breathing, because it's this 360-degree movement where, like an umbrella opening up, your rib cage should open up in all directions. Again, mostly outer movement here that you feel, but it will also move a little bit in the front and a little bit in the back too. So when you have your hands on your sides, just underneath your bra line, you should feel a little bit of movement into your thumbs with your ribs, a little bit of movement into the tips of your fingers with your